week during National Infertility Awareness Week. Tonight's topic is on a very common issue that I think we'll find out, I know we'll find out more about tonight. We are talking about fibroids tonight, and we have two wonderful doctors here with us who will explain more about that and who will be available for questions at the end of the presentation. So right now I'm going to let Dr. Jessica Shepard and Dr. Obehi Asemota introduce themselves and take it away. Thank you so much for joining us, doctors.
Absolutely. I'm actually very honored to do this with one of my really special colleagues who I did residency with, Dr. Obehi Asemota, who is a reproductive endocrinology and fertility specialist. And then I'm a gynecologic doctor who specializes in fibroids. So thank you to everyone who's joining us tonight. And I think just starting from the top, I think this is a wonderful way for Fertility for Colored Girls is bringing awareness to infertility and specifically tonight for fibroids. So, as we know, this is National Infertility Awareness Week. We wanted to reach out to women who might have questions or concerns about fibroids, or if you have some general infertility questions as well. So, the key is fibroids are very common in women. They affect up to 50% of women by the time they're 50, and for African American women, that number jumps to 80% by the time they're 50. So they are very common. The million-dollar question, again, is what causes fibroids. So we do know that they're the most common benign, meaning non-cancerous tumor in the pelvis. But what actually causes them is a question that we do have unanswered at this point. Now, we do have a few things that, point to fibroids that we may see or increase someone's risk of having a fibroid, but usually that will boil down to hereditary factors. And so genetically, if a female has fibroids, if their mother or grandmother has them, that's a good indicator that they may have fibroids and suffer from them as well. So I'm going to actually give a few minutes to Dr. Asemota to kind of introduce herself as well and some of her credentials and allow her to talk about specifically generally infertility. So take it away, Dr. Asemota.
Thank you, Dr. Shepard. And again, I like to echo Dr. Shepard's previous comments that it's such an honor to be in this forum spreading fertility awareness, infertility awareness, I should say. I am a reproductive endocrinology and an infertility specialist, so I see patients who are trying to get pregnant, who have difficulty getting pregnant, or who have difficulty staying pregnant. And this is such a special topic because, as Dr. Shepard said, not only are fibroids very common, but they're, like I tell my patients, if you put 10 black women in a room, 8 of them have fibroids. And, there's always a question, is it the fibroids that's causing my infertility? And, and Dr. Shepard will touch on this also, and not all fibroids are bad fibroids. Because it's so common, a lot of women are able to have children while still having fibroids. So, something we'll probably get into is that just because you have fibroids does not automatically mean you're infertile. It could definitely contribute to infertility, but depending on the location and the size of the fibroids, not all fibroids need to be removed.
Go ahead.
No, go ahead. I was going to say I'm going to send it back to Dr. Shepard. If you could touch more about the fibroid management.
Yeah, fibroids, like you said, a lot of it as far as how it interacts with infertility, it does not mean, again, it's not a directly correlated relationship that if you do have fibroids that you won't be able to conceive, and vice versa. If you can't conceive, it's because of your fibroids. So a lot of what we do know about fibroids is it really depends on location, size, and also the amount of fibroids. Just thinking of the uterus in general, it's a large muscle, and in the center of that muscle is a cavity where babies grow. And so the more or the closer to that cavity that fibroids are located, again, is going to increase your chance of, one, not only possibly infertility issues, but usually a lot of bleeding issues as well. So the closer that the fibroid is to that cavity, you're going to have bleeding issues. But it can also impact implantation, and therefore, one, it can hinder you getting pregnant, or if women do get pregnant, not allowing them to maintain the pregnancy because of the location of that fibroid. So again, that's something that can be addressed and obviously seen on ultrasound, and then discussing with your gynecologist, ways to manage that if it's a bleeding issue, and then also if it's an infertility issue, how to kind of address that fibroid, get it shaved down, and get your cavity optimal for implantation and pregnancy. So the other thing that I wanted to just quickly discuss is, again, fibroids are not necessarily a bad thing. Usually as a gynecologist, what we like to say is if you have fibroids but they're not bothering you, we don't like to bother it. So again, if it plays into an issue of infertility or recurrent pregnancy loss, say, and you're unable to, carry pregnancies to full term, then that's when we can intervene at that point. And the way that we would intervene, specifically when it's an infertility issue, is usually going to be some type of surgical management. Now, that doesn't necessarily mean it has to be a big surgery, because sometimes we can get that cavity into the cavity where babies grow and address the fibroid and take it down in what we call a hysteroscopic myomectomy. So again, it's a same-day procedure. It can be done same day. You go home and you can recover, and most likely in up to a week. Now, if you have a fibroid that is located close to the fallopian tubes, and the fallopian tubes are what carries that fertilized egg into the cavity where it's going to grow for the rest of the pregnancy, that again can be an issue in what could impact your ability to carry an egg in order to be fertilized. So if the fibroids are causing an issue for infertility because of that location, usually what we would recommend at that point is to address those fibroids with what we call a myomectomy. And a myomectomy for that can be done either abdominally, where we would make an incision, just like if you were to have a C-section, and then also it can be done laparoscopically, which is a minimally invasive way of having that removed with small incisions, again, but the same work is done, meaning taking out the fibroid and reapproximating and kind of restoring that uterus back to its normal size. So again, minimally invasive is what I specialize in, so I allow women to have that procedure done either laparoscopically or robotically, but it decreases in recovery time as well. So I'm going to actually throw it right back to Dr. Asemota and talk about infertility. Once these patients have, maybe had a surgical procedure, what are some of the issues outside of maybe just fibroids that you see with infertility? And if you could discuss just very, superficially the infertility issues that women come across.
Right, yeah. In addition to cavitary issues, as Dr. Shepard expertly explained, the fibroids that are inside the cavity or blocking fallopian tubes definitely can contribute to infertility. But other things to look at is, I always tell patients, let's not forget the man. Let's not forget the man. Up to 30 to 50% of the time, the male partner is a contributing cause to infertility. So while we tend to focus on women's issues, I always tell patients that, it takes sperm and eggs to get pregnant. So, we definitely have to evaluate the man the same time a woman is being evaluated. And then, as I said, it takes eggs and sperm. So other issues that could contribute to infertility is if there's something called a diminished ovarian reserve, and you can think of that as having like a diminished egg pool, because women are born with all the eggs we're ever going to have. So sometimes when you're older, your egg pool is diminished, meaning it doesn't have the amount necessary that might be able to help you conceive naturally. And depending on the severity of the diminished reserve, there are a few treatment options that could be offered. Anything from intrauterine insemination, also called IUI, which is usually given with some medications, and all the way to IVF. So those are treatment options for infertility. Other causes of infertility, so we've talked about fibroids being the cause, male factor, eggs, and then your fallopian tubes, right? Your fallopian tubes need to be open. So a woman that has blocked tubes, either from pelvic disease, prior infections, or if she has a, for example, as Dr. Shepard said, a myoma blocking her tubes, she also would need some infertility treatment, and that could range anywhere from surgery, for example, if the myoma or fibroid is blocking the tubes, or with IVF. But what I do want to say is infertility does not automatically mean IVF. I think that's a common misconception. We can do anything from minimally invasive surgery, just as Dr. Shepard alluded to assisted reproductive technology, which is IVF. So there's a whole plethora, there's a whole spectrum, there are whole options for infertility treatment. So, you know, when patients come, we always do a workup in terms of, okay, what's causing your infertility, and then we address those issues based on what we think the cause of the infertility is. And I'm going to give it back to Dr. Shepard to talk about also other minimally invasive approaches for infertile patients.
Yeah, so I think that was a great overview of infertility, and I think at least before we finish this specific call, I think one of the things, if you could go over as well, after the age of 35, some of those percentages that we see with, you know, decreased ovarian reserve, and just so women know to start having the conversation before a certain age doesn't necessarily mean that they have to do something about it, but at least knowing some of those numbers I think are very helpful, and which Dr. Asemota and I are very vigorous about telling patients these in our conversation with women, so that they have this information beforehand, and it's not something that we're looking back at and trying to scrape together pieces, you know, to have women get to the outcome that they want to. So through this call, I want women to really feel that the information that they're getting is useful, and also helping to empower them to know that when they have an infertility issue, if they have a fibroid issue, or if it's combined, you know, for fibroids that are causing infertility, that, you know, science and technology really has allowed us as physicians to really offer women so much more than we have in the past, and so to not get discouraged by that. And I think, you know, Dr. Asemota and I, you know, refer a lot of patients to each other, and I really do feel that just like if you're going to the hairdresser, or if you're going to someone who's providing you the service, if you feel that you don't have a connection, or you feel that you maybe want a second opinion, you should always feel that you have that ability to do that. And, you know, some of my patients feel like they want a second opinion. I actually encourage them to, because I want them to feel that they're part of the plan and that they have all the information that they need. And part of that is making sure that you're getting the information, you know, at each of your visits, and you feel like you're a part of the process. So the other issue I just wanted to talk to about regarding fibroids is that, again, it does not necessarily mean either, and I've heard this a lot too, is that you do not necessarily need a hysterectomy. And so sometimes that can be an issue as well, and what we have patients coming to the office with is that they might need a hysterectomy. So I will say one of the things when I do a laparoscopic myomectomy rather, which is again, taking out the fibroids and restoring the uterus back to the size or the shape that it was before, is that usually what we find is when we take out fibroids that way abdominally, is that they will usually need a C-section. And I think that's surprising for some people who have to go through myomectomy, that they may need a C-section at the time of delivery when they do get pregnant. And that's because we've made an incision in the actual uterine muscle. And so what we don't want is you to go through labor, and when you have contractions of the uterus in labor, that potentially can cause a problem, and the incision that was made to remove the fibroid can open up. And that can be somewhat catastrophic to baby and mom. So we usually do schedule a C-section before you get to term, usually at 36 or 37 weeks in your pregnancy. And so, again, I just want to encourage women again. One of my patients who is part of FFCG, Fertility for Colored Girls, is one of my favorite ever. but she, you know, did have a myomectomy. And after her myomectomy, she got pregnant, and we had a scheduled C-section, and it was one of the best stories ever, because her story is just so empowering, and I hope one day she's able to share it. But she was able, you know, after years of suffering for infertility, got pregnant, and then also had a fibroid issue, and we were able to remove that. And subsequently, she was able to conceive again and have another baby, and we did a C-section. Everything was great. So, Dr. Asemota, if you could go over quickly those numbers, I think that would be helpful before we kind of tailor off the call for questions.
Sure. And I just one thing I also want to add is when it comes to infertility, and I hope we've demonstrated to you, even fibroids, you're not alone, right? That's a big theme. You're not alone. Because sometimes I see patients coming to my office crying, and, you know, I tell them, you know, this is what I do, infertility. Trust me, you're not alone. A lot of women have these problems, and the great thing, as Dr. Shepard said, is that technology has come a long way, a long way. Women who previously, years ago, did not have a lot of options, now the technology has come such a long way that we offer patients a good chance of success. So what I normally tell patients is that natural fertility rate. So a woman who doesn't have any issues, who is fertile, each month her natural fertility rate is about 15 to 20%. People are normally shocked when I tell them that's the natural fertility rate. So normal fertility, chance of getting pregnant each month is about 15 to 20%. So depending on your reserve, meaning your egg pool, and if there are any other factors, the age being the biggest one, because as you probably know, the older you are, it's a little harder to get pregnant. Natural fertility is about 15 to 20%. So in fertile women, obviously it's less than 35. I usually quote about 10 to 15%. But the thing is, when you start using treatments such as insemination, such as IVF, you know, that the pregnancy rates could range anywhere from 10 to 15% all the way up to 45 to 50%, okay? 45 to 50% is when we use IVF. And just briefly, in vitro fertilization is where we take a woman's eggs, so we give her medications to stimulate her eggs. We harvest the eggs out, mix it with her partner's sperm or donor sperm, and then when we have a fertilized egg, that's an embryo, we then put an embryo in the uterus. So typically, a patient who's less than 35 years old, her chance of success doing IVF is about 45%. If she's doing insemination, where basically we're just shooting sperm into the uterus, success rate is about 10 to 15%. So compared to the natural fertility rate, you know, treatment options could bring you close to natural fertility rate or even over. Obviously, this all depends on the age of the woman, what the fertility issue is, but as I said, technology has come such a long way that we can offer most women a reasonable chance of success. And again, just going back to our main topic, which is fibroids. As long as the fibroid is not in the cavity, as long as it's not distorting the cavity, so the cavity is where the embryo or the baby implants, usually we don't have a problem with it. It's if, you know, a woman has symptoms such as bleeding, pain, if the fibroid is in the cavity or if it's blocking her tubes, that's when we intervene. But usually if the fibroid's not in the cavity and the woman doesn't have any symptoms, we just leave it alone. But I just wanted to say again, I'm really happy to be part of this forum to raise infertility awareness and talk about fibroids and options that we could offer to patients.
Yeah, and I echo that as well. So I kind of wanted to open up for questions, and we'll have the moderator have our questions. asked, and then we'll answer them for you.
Fantastic. Well, thank you all so much. And thank you both so much, doctors. Just excellent information. And so what we're going to do is for the folks who are online, you are more than welcome to send your question through the chat box. We have several callers who have joined us. So callers, here's what we're going to do, because obviously you can't send your questions through the chat. We're going to unmute your line. If you want to ask a question, this is a great chance to ask it. If you don't want to ask a question, you can just mute your own device on your end, and that way if you have any background noise, it won't interfere with the question and answer period. So I'm going to unmute all of our callers now. Thank you all so much for joining us, everyone. It's awesome. And we'll just see if we've got some questions. This is a wonderful opportunity to speak with two experts on this topic. So I actually have a question that I hope is pretty quick. If you find out you're pregnant and you don't know until then that you have fibroids, what are the chances of the fibroids interfering? Is it rare that they will actually interfere? I know that Dr. Asemota mentioned that if they were in the cavity, it kind of depends on where they are. But I guess how often, do you find out that, like, once you already have conceived that you have fibroids, and how often could those interfere? How often do you see those interfere if a woman didn't know she already had them?
Yeah, that's a great question. This is Dr. Shepard. Very often, because again, we quoted a rate of up to 80% of women have fibroids by the time they're 50. So many times during an ultrasound in pregnancy, we're like, oh, you have a fibroid. Now, if there hadn't been any bleeding early in the pregnancy or any, threats of miscarriage, then usually we leave them alone and we just, let the pregnancy progress. Now, with a fibroid in pregnancy, you do have an increased risk for possible preterm labor, possible bleeding, or possible postpartum hemorrhage. But if it's not interfering with the pregnancy, we typically leave those alone. Now, if it's something where you're early in pregnancy and you had either very heavy bleeding or a miscarriage because of the location of the fibroid, then that's something that we would address if you did miscarry or if one miscarried, because we would need to, again, work on that fibroid location and shave that down so that subsequent pregnancies wouldn't be affected.
Excellent.
Right. Yeah, I agree with that, yes. I'm just seeing a question that I should speak briefly about miscarriages. Just to talk about miscarriages very briefly. So 15%. And usually if a woman has had 2 or more miscarriages, we recommend a workup, so seeing a fertility specialist so we could see, because there are some known causes of miscarriages, some genetic causes or some what we call autoimmune disorders that cause miscarriages. So if a woman has had 2 or more miscarriages, she should definitely see a fertility specialist.
Okay, great, excellent information. Are there any other questions, either from our callers or from the chat? Don't be shy. We have 2 experts on the line, so if you have those burning questions. Another thing I think I'd suggest too is that even after the webinar is over, if you have a question that comes to you, you're more than welcome to message our Facebook page. Doctors, I don't know if you all wanted to share some contact information where perhaps some of the ladies and gentlemen, if we have them participating tonight, could contact you if they have any questions.
Oh, yeah, sure. Absolutely. Go ahead. You go ahead, Dr. Asemota.
Okay, so yeah, this is Dr. Asemota. I'm at the University of Chicago. So I see patients in Hyde Park. I also see them in Indiana, Northwest Indiana, and Orland Park. The easiest way to reach me would be to call my office number, which would be 773-702-6642. And again, this is at the University.
I usually have one site where I see patients. This is the Taylor Street office, and that actually is at 1801 West Taylor, but the best number to kind of get an appointment seen by me would be 312-413-7500. And then also through social media. I know Reverend Dr. Stacy Edwards has all my information, and definitely I'm part of the FFCG group on Facebook. So I would definitely be able to touch bases with patients that way as well.
Fantastic.
Yeah, I see that we have two questions here. I'm sorry, I didn't mean to interrupt. Just saying now some people are typing questions. Yeah, a question someone poses, are there any natural treatment options for fibroids such as diet or acupuncture? I'm going to refer this question to Dr. Shepard. She manages a lot more fibroids than I do.
Yeah, sure. No, I do hear, again, we're discussing at the beginning of the call that, the million-dollar question, what is the cause of fibroids? So, we do allude some dietary factors to fibroids, but it's not the only cause or the sole cause. Well, we do know that fibroids are part of an inflammatory process. And so what I do encourage all of my patients, because we have somewhat of a link, not a strong link, but we do know that women who are obese have an increased risk of having fibroids and also infertility issues. So, one of the things I encourage my patients to do is really look at weight loss and making sure that they're optimal weight, because we have a lot of patients who, when they decrease weight, they really are able to actually improve their fertility capabilities. And the other thing that we know that is inflammatory foods that can really incite inflammatory situations or environments in the body are going to be your high glycemic foods. So those are going to be your foods that are going to be your white flour, your white sugar, processed foods, and really decreasing as much as you can your red meat. So it does not mean that you can't eat red meat. It means that sometimes you should monitor how much you're eating, or have a look at your dietary intake and see how much you're taking there. The other thing that we try to encourage as well is really increasing your green leafy vegetables, making sure that you're eating as much green leafy vegetables as possible, and not getting those from any canned source, which is going to increase your sodium as well, which also increases inflammatory environments within the body. So I think diet has a big part to play in your overall health, but it's not one contributing dietary factor that's going to decrease fibroids. So that's a great question.
Okay, excellent.
Okay.
And then there are a couple of other questions. I apologize. My internet connection is being a little fuzzy. So yes, please, Dr. Asemota, take it away. There are two other questions that came in. If you could see those and read them, that would be fantastic.
Sure. So the other question was, what number is considered diminished egg reserve? So this is an excellent question. And it really depends on your age, but usually anything less than 1 is considered diminished. But like I tell patients, just because your ovarian reserve, and there are different ways we measure ovarian reserve. Let me take it a step back. There are different blood tests we do. One blood test is your FSH, which is done on the early part of your cycle, and another blood test is your AMH. So an AMH less than 1 is considered diminished, and FSH greater than 10 is considered diminished. But like I tell patients, it's a whole picture. So usually I don't focus on that number. I take into account, a patient's age, has she had any prior pregnancies. So the key numbers are greater than 10 FSH and less than 1 AMH, but that's just part of the story. So I hope that answers your question. And then there's a question here for Dr. Shepard. How long does it take to recover from a procedure to remove fibroid? How soon can you start to conceive?
Great question as well. So when we're counseling our patients for surgical procedures, again, we look at what type of myomectomy they're having. If they're having a hysteroscopic myomectomy, which is where we remove the fibroid through the vagina in the cavity of the uterus, this is a small procedure, a same-day procedure, and usually the recovery is really quick, anywhere from 5 to 7 days at most. Some people are able to go back to work within 3 days. Now, for an abdominal myomectomy, that's usually the longest because we do make an incision in the abdomen, and the recovery from that can range anywhere from, again, 6 to 8 weeks. We've had some patients who have had an abdominal myomectomy and bounce right back within 5 to 6 weeks, and that's great. For laparoscopic myomectomies, I tend to quote for recovery about 4 weeks to 5 weeks. Again, you have people who might take less or more time than that, and that's fine depending on, if they had surgical issues after the surgery, or if they have issues in general. Now, the big key picture here is for any of the laparoscopic or abdominal myomectomy, what we want is for your uterus to heal so that you don't get pregnant too soon and disrupt all that repair that we did on the uterus. So for a laparoscopic or an abdominal myomectomy, we usually like, outside of recovery time, we like you to wait about 4 months to possibly 6 months, depending on how much of a fibroid we took out and how much repair we had to do before we try to have you conceive. Doesn't mean you can't have intercourse, but it means that we don't want you to conceive. Now, for hysteroscopic myomectomy, actually a lot of patients will have them, once they have their next period, then we can have them start again, whether it's within in vitro or just trying spontaneously to get pregnant after their first period after the hysteroscopic myomectomy. So again, a great question.
Right. And there's another question. If diagnosed with high blood pressure, can that lead to preeclampsia when you are pregnant? Usually patients that have high blood pressure are at risk for what we call a broad category of hypertensive diseases of pregnancy, preeclampsia being one of them. So yeah, high blood pressure could definitely lead to complications in pregnancy such as preeclampsia. And usually what I do, and I'm sure Dr. Shepard does this also, is, patients that come in prior to pregnancy that have high blood pressure, especially if they're not well controlled, we refer them to a high-risk doctor or maternal fetal medicine to optimize their medical condition, make sure the blood pressure is well controlled prior to pursuing pregnancy.
Awesome. Awesome. Thank you all so much. And I just need to read this message from Reverend Stacy, who's tuned in from our chat. She says, Dr. J and Dr. O, thank you for tonight. You all are amazing, brilliant, bold, brilliant Black women doctors. Just in awe. God bless the work of your hands, minds, and souls. That blessed me. Hashtag Black Women Rock. Amen. Amen.
Yeah, that's pretty nice.
I completely agree. So we're going to wrap up for tonight, ladies. Thank you so much, doctors, for joining us. We just really appreciate it. Cannot thank you enough.
Oh, it's my pleasure. My pleasure.
Yeah, absolutely. Thank you again, and hope to be able to do a forum like this soon with Dr. Asemota.
Absolutely.
Yes, thank you very much.
And I have just a few announcements for everyone on the line. First of all, thank you for joining us tonight, for taking time to join us during our virtual summit for National Infertility Awareness Week. The summit continues tomorrow with another event. We're going to be talking about affordable treatments. So we've talked about some of the issues that you may be facing in your journey to fertility, and now we're going to talk about some of those remedies and some affordable treatments. I believe we're talking to fertility centers of Illinois and EMD Serono tomorrow. So please join us at the same time for that. And then I want to remind everyone, anyone on the journey to fertility, that the Gift of Hope application is open. The deadline is coming up, I believe, in June, so you have a little bit more time to apply for that, where we give, Fertility for Colored Girls will give grants to families. They'll assess your application, and they'll give grants to families to help them build the families of their dreams. So that's very exciting. And so if you don't know about that, about the Gift of Hope application, please log on to fertilityforcoloredgirls.org where you can get more information about that. And finally, if you haven't already done so, you must pick up a copy of the Hold On to Hope book that was recently released, authored by...
Great book.
Oh, it's fantastic. I mean, absolutely fantastic. I think I finished it in one night. I couldn't put it down. Real stories of real families and their journeys to fertility. So if you have not already done so, you definitely want to go to the Fertility for Colored Girls Facebook page or to the website and find out more information about how you can get the copy of Hold On to Hope. It will bless you, as well as give you some wonderful information about keeping that hope and just finding inspiration in the journey of other women and couples and families who are facing some of the same challenges that you might be facing. So everyone, thank you again for joining us tonight. We certainly hope you'll join us again tomorrow as we continue our virtual summit. Y'all take care and y'all have a wonderful night.
Thank you so much.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.